Welcome back. Now, this is the final part of basics of barium studies we are going to cover on the learner's domain platform. So let's quickly go through this, the fourth and the final part. Here you can see the spectrum of barium sheath, again the common slide, which we have already covered in almost all the videos. We are taking this common slide, but very important, just to summarize what till now we have already covered. Whenever we are suspecting any pathology in pharynx or esophagus or stomach, these are the two spectrum of barium studies, that is, these two things are available for us: barium swallow and barium meal. These two investigation under an oval structure is barium swallow and barium meal whenever there is pathology in the pharynx, esophagus or stomach. More the proximal pathology is, means prefer barium swallow. If esophagus, you can go for both depending on the indication. And the stomach, let's say antrum part or duodenum, the barium meal is preferable, right? Whenever we are suspecting any pathology in the small bowel here, the options available is barium meal follow through, which we are going to cover in this video. Then small bowel enema, the various options we have discussed in the previous video, the 5 options, including enteroclysis. All these things we are going to discuss in this video, the important points. Then finally, whenever we are suspecting any pathology in the colon, the large intestine, then the option available is large intestine, means including rectum. The option available is barium enema. I hope now the broad indications of these different types of barium studies is probably okay with you now. Now you can go through the various different types of studies and the anatomy wise the site that may be involved, and depending on the site involved we can choose one of the barium study among these if required. Okay, so barium meal follow through. Here you can see, just to give you an idea, the whitish, the minute features are not clearly visible in this area, abdominal radiograph, whereas even the inside of this bowel, the internal mucosal features can also be seen here in this part, the left upper portion of the abdomen. This is the vertebral column, the clearly visible minute microscopic, or rather I should say the internal mucosal patterns are also visible in this area, whereas in right side lower abdominal part, the small bowel that is there, these are sort of featureless. This is ileum and this is jejunum, right, on barium meal follow through. So barium meal follow through, BMFT, one of the important thing is BMFT is usually done only after the barium meal study, and if that barium meal study is coming normal, within normal limits. So in order to diagnose, this BMFT is required, and the site covered by this BMFT is from esophagus up to ileocecal junction, right? Now we have increased the site covered here. In barium meal, up to the proximal jejunum it was. Here, starting from the esophagus, it is coming up to the ileocecal junction, right? And the starting point, obviously, esophagus in both the cases, the barium meal as well as barium meal follow through. It is different from SBFT, small bowel follow through. Remember this. BMFT is different and small bowel follow through is different. BMFT also includes esophagus, the stomach, the duodenum, then jejunum and ileum up to ileocecal junction. Whereas the SBFT, we are directly injecting barium into the small bowel. Esophagus is not covered, stomach is not covered, right? In SBFT. Now, indications for BMFT. If we are suspecting small bowel obstruction in any patient, patient is presenting to us with distension of abdomen with all the features of obstruction, intestinal obstruction, and if we are suspecting a small bowel obstruction, patient is subacute intestinal obstruction, not acute obstruction, this could be one of the indication for barium meal follow through. If we have tried for enteroclysis intubation, I'll come to this word, what is enteroclysis intubation? After 10 to 15 minutes, it will be clear to you what is enteroclysis and what is enteroclysis intubation. If it has failed and failed enteroclysis intubation, now no choice, then as far as the barium studies are concerned, so we'll go with BMFT. If patient is suffering from Crohn's disease, again, for revealing or demonstrating the various strictures and mucosal lesions, BMFT could be one of the options in Crohn's disease. Similarly, what are the contraindications of BMFT? If there is distal obstruction, the first contraindication means barium meal follow through is basically we are supposed to cover the small bowel, right, up to ileocecal junction. But if we are suspecting any obstruction distal to ileocecal junction, that is colonic obstruction, don't go for BMFT, it is contraindicated. Okay. If patient is having perforation or suspected perforation, don't do this BMFT. Or if the patient is having paralytic ileus due to any cause, again in paralytic ileus, this BMFT should be avoided. Right? These are the three contraindications, important contraindications of BMFT. Okay. It looks like somewhat like this. The vertebral column, the stomach part, the small bowel, the arrow showing the small bowel, there's a pelvic girdle, right? Although picture is not very much clear, but this is how a barium meal follow through looks like. Okay. Then BMFT, what is BMFT? What are the things we are supposed to do in BMFT? After barium meal, 50 to 60% barium, the volume around 400 ml, should be given to the patient for BMFT. And after 15 to 20 minutes, we are supposed to take the film in patient prone position if we want to demonstrate the jejunum and proximal ileum. Let's say upper part or upper half of the small intestine, if we want to demonstrate, take the film after 15 to 20 minutes. If we want to demonstrate the lower half also, then additional films are taken at 20 to 30 minutes interval till ileocecal junction is opacified, till the barium reaches up to the ileocecal junction. We can take the additional films every 20 to 30 minutes interval, right, in BMFT. And this is how a better picture here. It looks like starting from here. This is the vertebral column, the midline, what I have drawn here, midline, right? This is the angular notch here, the smaller line, the straight line parallel to this midline. Here is incisura angularis of the stomach. This is the body of the stomach, right? The barium meal, we have asked the patient for barium meal, and in succession of this barium meal, what we have covered till now, we are doing barium meal follow through. That is in this for the small bowel, right? Now here is the antrum, the duodenal cap. This is the pyloric canal. This is the second part of duodenum. This is the third part of duodenum, and this is going behind it. And here is the duodenojejunal junction. Normally it is situated on the left side of the vertebral column, slightly towards left side. And then comes here the jejunum. Inside jejunum, the plica circularis, they can be seen, right? And here on the right lower side, this side is the ileum. Okay, this side. So this is how a barium meal follow through. It includes the barium meal as well as barium meal follow through. How this SBFT is different from barium meal follow through. In barium meal follow through, we were giving around 400 ml of barium, but in a small bowel follow through, we are directly giving 600 ml of barium initially. That is how it is different from BMFT, right? And this barium is directly going inside the small bowel, right? Directly giving. We are not observing or just recording the initial part of the film. You're directly giving 600 ml of barium in SBFT. This is how it looks like. This is for demonstration of ileocecal junction. Here you can see the ileocecal valve is there. This is the cecum, right? The area under the circle. This is the terminal ileum, and it is the patient is in supine with right side up position in order to demonstrate the right side organs. This is jejunum in this second one film. This is the duodenum C loop. This is stomach, and these are the ileum and the ileocecal junction in barium meal follow through as well as SBFT. Now next comes the barium studies for small bowel. The next important thing is also known as small bowel enema. The term is enteroclysis. Now this enteroclysis, it covers from jejunum up to ileocecal junction. Jejunum up to ileocecal junction. It is excluding the duodenum. This is important. How it is different from this barium meal and BMFT or SBFT? It is excluding the duodenum. It is only focusing on the jejunum, ileum as well as IC junction, enteroclysis. And for this, we'll have to intubate the patient. Enteroclysis intubation is done. The same words what we have just discussed around 10 minutes or 15 minutes back. So for this, the used tubes, the most commonly we are using this Bilbao daughter tube. It is almost 150 centimeter in length and 5 centimeter longer than guide wire to prevent perforation from protruding tube. It is 22 French made up of polyethylene. The 8 side holes are present, and usually the guide wire is Teflon coated, used with this tube. And this tube is used for enteroclysis intubation, means we are going through the nostrils, through the esophagus, through the stomach, through the duodenum, and we are just intubating the jejunum or at the duodenojejunal junction in order to put the barium directly inside the jejunum, right? This is small bowel enema, enteroclysis. Other tubes that may be used, the Hurlinger tube, Maglenti tube, and Nolan's tube. These could be one of the MCQ in your NEET or your Viva Voce. The tube, this Bilbao daughter tube somewhat looks like this, a sort of non-traumatic. And this enteroclysis method, the position of the patient, usually the patient sits with chair to the wall Patient may be in supine or right lateral. This BD tube without guide wire is introduced into the nostril, and we ask the patient to swallow it. And during swallowing action, we advance the tube till it reaches the stomach. Then, if the guide wire is required, use the guide wire. We adjust the air content, the insufflation or aspiration. Means if the air is more, aspirate some air, or if the air is less distension is there, insufflate. Right? So what is the take-home message for enteroclysis? Enteroclysis means barium is being introduced directly into the small intestine. Right? This is enteroclysis view. You can see the upper left hand, the left upper abdomen, the jejunum, and the right lower abdomen, ileum, the enteroclysis view. Again, there is single contrast and double contrast view. In single contrast view, again 20% weight by volume barium suspension is injected. The average speed is around 100 ml per minute. The average time to reach it takes around 15 minutes. Single contrast means we are only using barium suspension. On fluoroscopy, we are supposed to follow the head of the barium column. And two films we are going to take. One spot film is for jejunal loops to demonstrate the jejunal loops, and the second spot film for entire small bowel. This is single contrast view enteroclysis, also known as small bowel enema. Right? Now, advantages of enteroclysis. Desired rate of contrast administration is there. Whatever we want, only that much rate we will use to administer the barium contrast during the study. So desired rate is there. Pylorus is bypassed. We are directly putting barium just distal to the pylorus. So pylorus is bypassed. Tube can be used for decompression also. If very much distended, we can use the same tube, the BD tube, for decompression also to relieve the symptoms. Then controlled, and after the study, even we can decompress it if required with the help of this BD tube. Controlled infusion is there. Controlled infusion of what? Controlled infusion of barium. So better dilatation is there. So detailed information is available. Even minimal narrowing can be detected, and there is lesser segmentation and flocculation. Okay. If the enteroclysis is having some advantages, so must be having some disadvantages also. And what are the disadvantages? Sometimes intubation of small bowel is unpleasant for the patient. We can have an idea, yes, we are directly intubating the small bowel, it may be unpleasant, agree. And sometimes even intubation is difficult, yes, it needs more expertise, and it is more time consuming also. And the most important disadvantage of this enteroclysis is during the screening of the placement of tube into the position, placement of that BD tube for this study, patient is exposed to higher radiation dose. So higher radiation dose risk is there. This is one of the important disadvantages of enteroclysis. Even more than the nowadays available contrast enhanced CT scan. So that's why instead of enteroclysis, nowadays widespread availability of computerized tomographic scan, contrast enhanced, this is frequently used instead of enteroclysis. Now, what are the differentiating findings between jejunum and ileum? How to identify during enteroclysis or barium meal follow-through? Especially in enteroclysis, we are talking about jejunum, there are 4 to 7 folds per centimeter. 4 to 7 folds per centimeter, right? whereas in ileum only 2 to 4 folds per centimeter. Proximal 2/5 of the small bowel is jejunum, distal 3/5 ileum. Valvulae conniventes are visible here. You can see the valvulae conniventes. Valvulae conniventes basically the mucosal folds of the jejunum. The prominent mucosal folds are there. They are known as valvulae conniventes. Whereas the ileum is featureless. As we are moving from proximal to distal towards the IC junction, these prominent mucosal folds, they are disappearing. And in the ileum, it is almost, the ileum is featureless in enteroclysis X-rays. And jejunum, the larger lumen, you can compare here as compared to the ileum. This is having a smaller lumen. Just compare this part, starting from, just focus on the cursor. Just compare this lumen, the diameter of this lumen, with this one, right? Obviously, the first one is larger. This is jejunum and this is ileum. Okay. Now, just comparing, we are just comparing here, not differentiating enteroclysis versus barium meal follow through. In enteroclysis, contrast administered as desired rate. I'm just covering the enteroclysis first, the summary part. The distension of bowel can be assessed. The pylorus is bypassed. The bowel proximal to stenosis dilates, and that's why it is easy to identify the strictures in enteroclysis. Time taken is around 20 to 30 minutes, and due to direct rapid infusion, it produces hypotonia in the small bowel. But the important thing is it is superior to BMFT and reliability is high. Enteroclysis, whenever we are just comparing these two, the superior one is enteroclysis whenever small bowel diseases are concerned. Whereas in BMFT, these are usually indicated in critically ill patient, the patient who are elderly, the patient who cannot be intubated with this BD tube. So barium meal follow through is one of the option available. Even if this enteroclysis is not possible in those patients, the BMFT is another option. There is no discomfort as it is seen in enteroclysis during intubation. There is less of radiation exposure in BMFT as compared to enteroclysis. One of the advantages in BMFT is we can assess the transit time of the stomach, of the small bowel especially. Then overlapping and poor distension of bowel loops, one of the important disadvantage in BMFT. It requires more time, prolonged study, and it gives less details in comparison to enteroclysis, this BMFT. So in this slide, we have just discussed side by side the enteroclysis as well as BMFT, as well as a few points for comparison. Role of double contrast in enteroclysis. 1/5 double contrast, just remember barium with air or CO2 producing substances. In combination we are giving. So double contrast in enteroclysis, 150 to 500 ml of high density barium, 80 to 100 ml per minute is the rate. We observe the head of barium under fluoroscopy. Air contrast shows detailed mucosal changes like small ulcers. The advantage is it does not distend the intestine. It also does not dilute the barium. Sinuses, fistulae, and stenosis may be overlooked. Why? Because it is not distending the intestine in double contrast. It is good for mucosal lesions, double contrast. Here you can see this is double contrast. This is transverse colon. This is cecum. This is the left side colon. This is sigmoid colon. And this is the ileum and here jejunum. The double contrast. You can see the barium as well as the air, the black area. Another important terminology is peroral pneumocolon. What is the purpose of this peroral pneumocolon? Peroral means through the oral cavity, and we are giving air, air, and that air is going up to the colonic area. So purpose is to evaluate the distal ileum and ileocecal junction. Air is insufflated after barium reaches the transverse colon through that tube, the tube, BD tube, that is being used in enteroclysis. So this is another investigation, the specialized one, the peroral pneumocolon, to better visualize or evaluate the distal ileum and ileocecal junction. Peroral pneumocolon. Right? Now finally, if we are suspecting any lesion in the large intestine, the option available is barium enema. The indications for barium enema, this is the last spectrum of the barium studies used in gastrointestinal tract. If the patient is suffering from rectal bleeding or rectal polyps discovered on proctoscopy, or if patient is giving history, family history of rectal polyps, recent change in bowel habits, or recent significant weight loss, and if there is long-standing inflammatory bowel disease. So these are the indications for barium enema. Barium enema means, now in this case, barium contrast is being given through the anal opening using a tube, right? Contraindications of barium enema, as usual, the suspected perforation, recent rectal or colonic surgery or biopsy we have taken from this area, either the rectum or the colon, then acute colitis or diverticulitis, and toxic megacolon. These are the contraindications for barium enema. What we are supposed to do, so pre-procedure preparation, important points. Patient should be kept nil per oral for at least 12 hours, and adequate bowel preparation should be there. We can give Teglik also. Low residue diet should be advised for the patient for the last 48 hours, mean last 2 days. Patient must be having low residue diet. Then plenty of fluids orally should be given on previous day to prevent dehydration, and oral laxative should also be given on the previous day for this study, barium enema. Soap water enema previous night, and in the morning of the study day, plain water enema should be given, right? So barium enema, again, few important methods, double contrast as well as single contrast. In double contrast, for mucosal lesions, I have already explained to you, for mucosal lesions, double contrast study is better. The method of choice for barium enema, double contrast. If we want to localize the colonic obstructive lesions, or in children, usually not necessary to demonstrate mucosal lesions. The children, they are not usually the sufferers in early age. Or if we want to reduce the intussusception, reduction of an intussusception. These are the important uses of single contrast barium enema. No air is required. Single contrast barium enema uses a 3. And if you want to look for mucosal lesions, choice is double contrast barium enema. Lesions where? Lesions in the large intestine. Barium enema means large intestine. Okay. Double contrast. Patient either should be prone or left side down oblique position. Air introduced in the prone position. Why air? Because double contrast. Frontal view in prone position followed by left lateral for lateral view. For rectosigmoid area, if you want to see, oblique right side down position is used. These positions you can just visualize in your brain, and you will be better able to understand it. For double contrast, air and barium both are required. These are different site, according to the site, various positions we can go with. In patient in left lateral, the technique we are just discussing in very short, Ask the patient to lie in left lateral position. Catheter is inserted into the rectum. Give an IV injection of Buscopan 20 mg, antispasmodic. So start the barium infusion up to the splenic flexure in left lateral position. Then turn the patient prone. Contrast will run to the hepatic flexure. Stop the contrast when it tips into the right colon. Patient rolls onto their right and quickly onto their back. Then occlude the catheter tube. Now for double contrast, air is gently pumped into the bowel to produce the double contrast effect. Right? This is the common technique for single contrast up to this level, and including this last two lines becomes double contrast. Now these are the spot radiographs we are supposed to take. This is probably the last or second last slide. The prone position, rectum is better visualized, and in left lateral position, rectum is better visualized. For sigmoid colon, left posterior oblique position. For rectum and cecum, supine position is fine. For hepatic and splenic flexure lesions, the upright position is good, and rest of the remaining colonic segments can be better visualized on supine or supine oblique position. Here you can see this is barium enema. This hepatic flexure, the transverse colon, right? Double contrast, air as well as the barium enema is there. The barium is there. Again, another picture of this barium enema. This is transverse colon, very beautifully delineated here. This is cecum. This is splenic flexure. This is hepatic flexure. And this is sigmoid colon, the rectum, right? And again, the double contrast, the barium as well as the air. So this is one of the example of barium enema, right? So that is all from my side regarding the basics of barium studies in GI tract. I know it's slightly lengthy, the fourth one, the final part, but it's okay. So these were the basic points covering the basics of barium studies in GI tract. Thank you. Any query? Still, we can again, after few weeks, we can again finally give a supplementary video regarding the barium studies if it is required. So thank you and namaste.